This will be the last session we're going to have for a couple of weeks. We're going to break the next 2 Mondays for Thanksgiving break. We'll pick up the first week in December. And the first Monday in December, we're going to be having an attorney who will be addressing the group on contract negotiations. We figured this would be a good time to have that discussion, just because so many people are beginning to look at job opportunities, and he's got some really good advice. So we'll do that for a happy hour session. And then the second Monday in December, we'll go ahead and do cases. I'm going to be running that session. Then we'll take a Christmas break and start up again in January. And so if you have any topics that you would like to see discussed in January, any differentials, any particular areas of interest, please feel free to email us at sagis@education.com, or you can email me directly at tdavis@sagisdx.com, or April's got my phone number up there, so please feel free to call or text as well. Excuse me, I'm a little bit hoarse, I'm sorry. Today we're going to be focusing in on dermal matters. And so as those of you who've had a chance to take a look at the slides know, the focus is kind of on disorders of collagen and elastic tissue. And we're going to be looking at 4 disorders to begin with, characterized by sclerosis, then 4 disorders characterized by fibrosis, then a couple of miscellaneous disorders, and then we'll close out with 2 perforating disorders. And just for the sake of definition, we define sclerosis as thickening of the collagen bundles, kind of homogenization without an increased number of fibroblasts. Fibrosis, on the other hand, we get the thickened collagen bundles, but we have in that instance an increased number of fibroblasts between the thickened collagen bundles. So kind of keep those 2 definitions in mind as we proceed. So we'll go ahead and start with our first slide. Our first biopsy specimen is a punch biopsy from the trunk. You can see that the dermis was squeezed here, and this is why we don't like people to do a punch and then pick it up with forceps, because you kind of squeeze the dermis can be squeezed. And if you've got a neoplastic or inflammatory infiltrate in the area where it's squeezed, it can be very difficult to kind of discern the nature of the cellular infiltrate. So anyway, punch biopsy from the trunk. And as we move into a little bit of higher power, one can see that there is a little bit of compact orthokeratosis. The epidermis is actually fairly thin with the effacement of the reed ridge pattern. And what catches your eye right away is pallor, excuse me, in the papillary dermis. And we can see that the papillary dermis in this instance is thickened by very homogenized collagen. And there's actually, in addition to that, and let me get my pencil out here, a little bit of edema beneath the dermal epidermal junction as well. So this homogenization of the collagen is sclerosis, okay? And that's very characteristic of this condition. You can see it's limited to the papillary dermis. Then beneath the zones of sclerosis, in this instance, we have a patchy band-like infiltrate of lymphocytes. If we look along the dermal epidermal junction, you can see that there is a little focal vacuolar change, not only along the dermal epidermal junction, but also along the dermal follicular interface. We have a few slightly dilated vessels and an occasional melanophage. So taken together, these findings are diagnostic of lichen sclerosis. The condition, as I'm sure many of you have heard before, has been described as having a flag sign, red, white, and blue. So when you look at the specimen from lower powers, from scanning magnification, we see the red or pink, which is the stratum corneum, the white, which is the expanded papillary dermis, which is very pale with edema and sclerosis. And then the blue is the band-like infiltrate. And lichen sclerosis is kind of our prototype of an inflammatory disorder in which the sclerosis is limited to the papillary dermis. The condition can be pruritic, and so sometimes one will see superimposed lichen simplex chronicus. And sometimes because it's pruritic and gets scratched, you can actually get quite a bit of hemorrhage in the papillary dermis. And then one last point, recently, people have begun to recognize, and it's been written about in the Dermpath literature, that early LS sometimes will have a few eosinophils within the infiltrate as well. So lichen sclerosis. Now, the next slide that we're going to look at is one of the key items in the differential of lichen sclerosis. Let me go ahead and flip the slide. And here we have a trisected punch biopsy. And even at scanning magnification, you can see that there are some similarities to the biopsy we just looked at. The cornified layer here is thickened, in this case by compact orthokeratosis and a little bit of parakeratosis. Once again, the epidermis is thin with effacement of the reedy ridge pattern. And let's back out a little bit. One can see that the papillary dermis here appears to be somewhat thickened by very homogenized collagen. You know, if we move into higher power, you can't really make out the collagen bundles. They're kind of thick, fused together, and very homogenized. I'm going to back out a little bit here because what's notably absent in this biopsy, which was present in the last specimen that we looked at, are one, an inflammatory infiltrate. So take a look, there's no inflammatory infiltrate here in the dermis. And two, there's no adnexal structures. They're gone. In addition, a couple of notable things in this biopsy specimen. We have widely ectatic vessels. So these are much more dilated than we saw in lichen sclerosis. And you can see them in the papillary dermis. They're kind of variable in size, but much more widely dilated. They are lined by uniform endothelial cells. And then beneath the zones of sclerosis, you can see we have elastotic material here. This kind of gray, these almost look like gray spaghetti fibers that are fused. So we have elastotic material here in the dermis. And then kind of the icing on the cake, if we look in the papillary dermis, we can see scattered, plump, kind of stellate fibroblast. And these are radiation fibroblasts. This, of course, is chronic radiation dermatitis. And it also is characterized by sclerosis, which tends to be most pronounced in the papillary dermis. Sometimes it'll extend a little bit deeper. One generally gets destruction of the follicles. Occasionally, you can see a few retained eccrine coils. It typically is pauci-inflammatory. One of the histologic hallmarks are widely dilated vessels within the papillary dermis. The epidermis can be thinned in areas and hyperplastic in others. One tends to see the plump stellate fibroblasts, the radiation fibroblasts, and then one will always see radiation elastosis within the underlying dermis. So a lot of similarity between LS and chronic radiation dermatitis, but again, the absence of an inflammatory infiltrate, the absence of adnexal structures, the large dilated vessels are all features which are more indicative of chronic radiation dermatitis. Okay, let's go ahead and continue our discussion of sclerosis. And the next biopsy specimen was a bisected punch biopsy specimen. This was from the trunk. We've got a very thick dermis here. And let's go ahead and focus on this piece. I'm going to tilt the slide a little. And before we move in too closely, what you can see is we've got a superficial and deep perivascular infiltrate here. And in the lower reticular dermis, you begin to see that the collagen bundles here are a little homogenized or sclerotic. There's no real increase in the number of fibroblasts, but these are very sclerotic or fused. The biopsy has a very square configuration, okay? And if we look down around the eccrine coils, we can see that there's a loss of the periappendigeal fat. The fat has been replaced by these thickened sclerotic collagen bundles, which are kind of encasing these eccrine elements, which are becoming a little atrophic. If we look at the inflammatory infiltrate, which is both superficial and deep, we begin to see lymphocytes. And in addition, there are a few scattered plasma cells within the infiltrate as well. Again, the collagen bundles are very homogenized. And we have a similar infiltrate in the upper dermis, but the dermal collagen in the upper reticular and papillary dermis is not quite as sclerotic. You can see spaces between the collagen bundles that you can't in the deeper reticular dermis. And of course, this is Morphea, which is kind of our prototypical example of a sclerosing dermatitis in which the sclerosis is present in the deeper reticular dermis. Occasionally, one can see LS-type changes in the papillary dermis overlying Morphea, in that the papillary dermis looks very homogenized. But what's different about the LS changes you see in Morphea as opposed to LS is that you don't get the band-like infiltrate. A couple of other conditions which can give you histologic changes identical to Morphea are radiation dermatitis. Not radiation dermatitis, excuse me, are chronic graft versus host disease. And occasionally the sclerodermoid plaques in Porphyria cutanea carta can look histologically indistinguishable from Morphea, as can the sclerosis induced by bleomycin. So certainly on a board exam, if I saw a biopsy like this would be Morphea all day long. But just be aware of the fact that, again, chronic graft versus host disease, the sclerodermoid plaques in PCT, polyvinyl chloride exposure, bleomycin, they can all give you similar sclerosis in the dermis. And slide 4 is the last of the sclerosing conditions that we'll consider. Here we have a trisected punch biopsy. And as we zoom in, you can see that the epidermis and dermis are largely unremarkable. There's a little bit of thickening of the septi in the subcutaneous tissue, but what's most striking is present below the subcutaneous tissue in the fascia. And this fascia is markedly thickened, and it's characterized by both fibrosis, an increased number of fibroblasts, and sclerosis. We've got these thickened collagen bundles, as well as a little bit of edema here. And if we look at the infiltrate, one can see scattered lymphocytes, and in this case, eosinophils as well. So we've got a thickened fascia with a mixed inflammatory infiltrate containing lymphocytes, eosinophils, and some sclerotic collagen bundles. And of course, this is eosinophilic fasciitis or Schulman syndrome. Now, this particular biopsy is kind of unique because I would have to say most biopsies of Schulman syndrome or eosinophilic fasciitis that I've seen, I haven't seen eosinophils. The eosinophil or eosinophilic referred to in the name generally refers to peripheral eosinophilia. And of course, this condition is characterized by the sudden onset of edema and pain, firm indurated plaques, usually on an extremity following vigorous exercise. And a lot of people feel that it is within the spectrum of Morphea or scleroderma. So we've kind of started with our sclerosis up top in the papillary dermis, looking at LS and radiation dermatitis, then looked at a condition characterized by sclerosis in the deeper reticular dermis and now in the fascia. Occasionally, just one point to make before leaving, biopsies of morphea, let me go back to that slide here, can occasionally, the sclerosis can occasionally extend from the reticular dermis into the underlying fat. And when that occurs, we talk about morphea profunda, kind of like we talk about lupus profundus when we see the changes of lupus in the fat. Now, whereas lupus produces a lobular paniculitis with hyaline necrosis of the adipocytes, in morphea, we actually see a septal paniculitis. So what you'll begin to see, and we can see a little bit of that here, the fibrous septae become thickened by very thickened sclerotic homogenized collagen bundles. So morphea is a little bit like necrobiosis lipoidica in that sense. Both of those conditions will produce more of a septal paniculitis than a lobular paniculitis. Okay, so let's go ahead and move on to our group of fibrosing disorders. We'll start with slide 5. We have a trisected punch biopsy here. And one can see that the epidermis is actually a little bit hyperplastic here with some elongation of the reedy ridges. What's notably absent in the central portion of the biopsy specimen is adnexal structures. And that's one thing you'd want to note right away. There are some dilated vessels present within the dermis. And if we move in to slightly higher power, we begin to see that the vessels have a north-south orientation. They're oriented perpendicular to the dermal-epidermal junction. And within the dermis, we have thickened collagen bundles and an increased number of fibroblasts that are oriented more or less in an east-west direction, parallel to the dermal-epidermal junction. And the combination of fibrosis with an increased number of parallel fibroblasts and thickened collagen bundles, vertically oriented blood vessels, and absent adnexy is diagnostic of a scar. And it's kind of important to be able to recognize a scar. I don't think we talk about it a whole lot when we're covering Dermpath, but when, for instance, as a dermatopathologist, we're looking at re-excisional specimens, you always got to make sure that there's a surgical scar there. It's kind of a double check to make sure that the correct site was actually treated and excised. Now, a lot of times in a scar, the epidermis will be thinned with effacement of the reedy ridge pattern. We just don't happen to see that here, but absent adnexal structures are key. And if you're struggling trying to figure out whether something's a scar or not, we can always throw on an elastic tissue stain, like a Bierhoff von Giesen, and you get a marked reduction or absence of elastic tissue within a scar. This particular biopsy had a little added treasure here before, in addition, rather. We've got, and we covered this a few weeks ago, we've got a pool of kind of bluish gray bubbly material in the dermis. And this is intralesional Kenlog. This is Kenlog that was injected. This must have been somewhat of a clinically hypertrophic scar, but not really histologically. Got another pool of triamcinolone down here in the dermis. So we had a little bit of a twofer here. And again, you know, one caveat that we always try to teach people in Dermpath is never be pleased with just one diagnosis. Make sure you look around to see if you have more than one thing going on. Okay, continuing our discussion of things fibrotic, I'm going to flip the slide. And what's striking here, you know, it's you can see it looks like the epidermis was kind of pulled down, almost like we have a little pit here in the dermis. And if we look at the collagen here, you know, we can see some spaces between the collagen bundles. They look relatively normal. Same thing over at the other edge. But centrally, you know, we kind of have a nodular growth here. And again, there's absent adnexal structures in the central portion of the specimen. If we move to higher power, very similar to the last case, we see an increased number of fibroblasts and we see thickened collagen bundles. But in this case, rather than being arranged parallel to the dermal epidermal junction, we begin to see that we've got nodules. I'm going to try and lock the slide in here. I'm sorry. We've got nodules and whorls, not only of fibroblast, but thickened collagen bundles. And so we don't have that nice parallel arrangement, nor are the vessels all perpendicular to the blood vessel. And anytime we get what looks like a scar, but is characterized by nodules and whorls of fibroblast, that's what defines a hypertrophic scar. So we're kind of looking at the spectrum of scars here. First one, parallel fibroblast east-west with north-south blood vessel scar. If we begin to see more of this nodular arrangement, we've got a hypertrophic scar. And then finally, our next slide, dome-shaped nodule. And this is kind of at the other end of the spectrum. If we take a hypertrophic scar with these nodules and whorls of fibroblast and thickened collagen bundles and add these brightly thickened eosinophilic collagen bundles that are kind of broad and interconnected. This, of course, is keloidal collagen, and this is a keloid. And a keloid really is nothing more than a hypertrophic scar characterized by these broad eosinophilic bubblegum-like or bubblegum-covered collagen fibers. So hypertrophic scar, keloid. Important to understand that distinction. And then we'll close out our discussion of fibrotic disorders. Let me flip the slide with this biopsy, something a little bit different. So we've got an incisional biopsy specimen here. There are a lot of hair follicles, and we're up near the head. This is actually from the neck. And if we take a look at the top piece, again, if you look at the left side of the biopsy specimen, you can see right here that I'm circling, we have adnexal structures. Same thing over on the right half of the biopsy specimen, but they're absent in the central portion. And we have a superficial and deep perivascular and perifollicular infiltrate of lymphocytes. If we go in and take a look at the infiltrate, we begin to see that we also have lots and lots and lots of plasma cells. The infiltrate has a nodular quality, and we begin to see that we've got fibrosis, increased number of fibroblasts, thickened collagen bundles, and some of these are arranged in vague whorls. You can see right here, and again right here. It doesn't have that nice parallel orientation that we saw with a typical scar. So we've got hypertrophic scar with an intense lymphoplasmacytic infiltrate, but we've also got an active folliculitis going on here. So you can see where the follicular epithelium used to be. We've got granulomatous inflammation. We've got a lot of naked hair shafts in the dermis. Some of them are engulfed by multinucleated histiocytes. Again, you can see a little remnant of follicular epithelium here. Again, these naked hair shafts. And here you can see we've got actually a little focus of suppurative folliculitis, which is ruptured. And so what we've got here is acne keloidalis nuchae, which is basically, in most instances, a hypertrophic scar. As Elston points out in this text, the keloid is in the name. And here you can see the neutrophils. So we've got this suppurative folliculitis that's rupturing and is periodically active, kind of waxing and waning. And most chronic recurrent suppurative folliculitides are characterized by fibrosis and will frequently be accompanied by a heavy lymphoplasmacytic infiltrate. And in actuality, this is very difficult to distinguish from folliculitis decalvans or from just a chronic deep-seated suppurative folliculitis, for instance, such as you'd see in acne conglobata or even in hidradenitis. Although in those instances, you will usually see ultimate development of a sinus tract, which you don't see here. So again, if you see on a board exam a hypertrophic scar with naked hair shafts and evidence of a suppurative folliculitis, where they're going with that is usually acne keloidais. Okay, let's go ahead and move on to our last 4 slides. The first slide was, at first blush, a little underwhelming. We have a punch biopsy, and the epidermis is of normal thickness. It's a little bit squared off. The dermis is clearly thick. There's no adnexal structures. The collagen bundles are somewhat enlarged, but they're not really sclerotic, We can see increased spaces or clearly spaces between these collagen bundles. They aren't kind of homogenized. There's also no real increase in the number of fibroblasts. But what we do notice that these collagen bundles are kind of haphazardly arranged. They're kind of going in a variety of angles here. And there's no accompanying inflammatory infiltrate. Look at the collagen bundles in the dermis, a lot of them they are arranged kind of in fascicles, but most of them are parallel to the DEJ. These in the reticular dermis are enlarged and haphazardly arranged. And this is the type of change one sees in a connective tissue nevus. Connective tissue nevi can be composed of excess amounts of collagen or thickened collagen bundles. One can see an increased amount of ground substance, or one can see an increased amount of elastic tissue, or any combination of the two. This is a collagenoma. The collagen is actually thickened and characterized by this haphazard arrangement. A lot of times when we see these histologically, if we're thinking about it, we'll get an elastic tissue stain. If the elastic tissue stain is absent, then that's very suggestive of a collagenoma. But the elastic tissue can be normal or increased in a connective tissue nevus. So we really kind of have to have clinical pathologic correlation to make the diagnosis with absolute certainty. A lot of times if we see this type of change, we'll suggest a connective tissue abnormality such as a collagenoma, but it's nice to be able to correlate that finding. So subtle change, and again, clinical pathologic correlations required. But what you want to look for are thickened collagen bundles that aren't necessarily sclerotic. There's no fibrosis, no inflammation. You could also think about the possibility maybe in this biopsy of scleroedema, because there you get a real thick dermis and the collagen bundles appear somewhat thickened. But in order to make the diagnosis of scleroedema, you have to have mucin present between the collagen bundles, and there's no mucin here between the collagen bundles. So, go ahead and move on to our next case. The next case doesn't get biopsied very often, just a beautiful example, and you kind of need to look at it at scanning magnification or low power to make the diagnosis. Here we've got a lot of milia in the dermis. You can see these cystic dilatations, which are filled with laminated keratin. You actually have trichostasis spinulosa here with a lot of little hair shafts. And one can see stratified squamous epithelium with retention of a granular layer. So these are milia, or small follicular cysts. In addition, there are in these sections some comedones, some dilated follicles filled with keratin plugs right here. And in addition, we've got a lot of solar elastosis. And so this is what one sees in Favre-Racouchot, or nodular elastosis with cysts and comedones. These patients usually present, as you well know, with kind of yellowish plaques on the cheeks that are studded with comedones and cysts. Almost always occurs in smokers. Occasionally we'll see biopsies like this because the excisions are done for cosmetic reasons, usually no cell or elastosis. So Favre-Racouchot, just as an example of a disorder of elastic tissue. Okay, and we'll close out with a look at a couple of perforating disorders. Slide 11 was a little tough because, you know, it was cut slightly at the edge of the lesion, but this is how we encounter them in practice. This was a bisected shaved biopsy specimen. As we move to higher power, one can see that there's an infiltrate within the dermis, kind of hard to say what it is. And there's also a little bit of squamous epithelium adjacent to the infiltrate, kind of encircling it. As we move to higher power, we see neutrophils, but we see an increased number of these somewhat refractile, brightly eosinophilic and enlarged elastic fibers. And this is a very characteristic appearance for elastic fibers that are hyperplastic in this condition. Brightly eosinophilic, not as thick as collagen bundles. And in this particular condition, they're increased in number. And they're usually being eliminated through a channel, a squamous line channel, which connects with the epidermis. And so what we've got here is elastosis perforating serpiginosa. We just don't happen to see the attachment here to the overlying epidermis. And of course, EPS can be seen in a wide variety of conditions. I would make sure that you familiarize yourself with the list of the various conditions which can produce EPS. And clinically, it's characterized by a coalescence of umbilicated papules, usually forms kind of an arsiform type of configuration on the neck or on the face or sometimes on the arms. So EPS. We'll go ahead and look at our next case, which was an example of RPC, and talk about the differences there. So both are perforating disorders. With RPC, unlike EPS, and it was difficult to appreciate in the last section, one tends to have a broader, kind of cup-shaped transepidermal elimination channel, usually is kind of squared off, and one has a big kind of neutrophilic plug, usually admixed with serum, kind of a scab on the surface. And one sees basophilic collagen bundles vertically oriented in the channel. You can see a few of these here. They aren't as brightly eosinophilic, and again, the channel is much more cup-shaped and broad. In EPS, I'm going to go back there. The fibers, again, are typically narrow, and the elimination channel is much narrower too. It's almost as if the elastic fibers are being sucked up in a vacuum cleaner. And the elastic fibers are clearly increased in number in EPS. So clinically, not too much difficulty distinguishing them, but histologically, sometimes it can be a little bit of a challenge. So look for a broader transepidermal elimination channel in reactive perforating collagenosis. Let me see, I do have one question here on the chat. So how are you able to differentiate the collagen from smooth muscle and the collagenoma? So we'll go back to that. We've got a little bit of time. We can take a look. Okay, and let's flip this. It's helpful, you know, sometimes if you have a smooth muscle bundle in the dermis, but I don't think we had one here because there weren't any. Oh, maybe right here. No. Oh yeah, here's a smooth muscle bundle. Okay, so that's great. We just happen to have one here. We've got a little trapped erector pili muscle. Okay, so you can see that, and this erector pili muscle is cut cross section. So you can see the nuclei with the perinuclear vacuoles. You know, we've got these little glycogen snacks here, and the nuclei here. And so it's a little bit difficult when the nuclei are cut in cross section like this. If you see perinuclear vacuoles, that's great. The nuclei of fibroblasts tend to be smaller than those of smooth muscle. So if you're having trouble, see if you can look around and find an erector pili muscle or smooth muscle maybe in a vessel wall and compare the fibroblast in the two. Here is another example. Okay, so we have, let me get my pencil here. We've got the vessel here, and you can see it's got smooth muscle in the wall. And these nuclei are a little larger and more blunt-ended than the fibroblast here. And of course, the collagen has a different color and a different appearance than the cytoplasm of smooth muscle cells. So hopefully that helps. If you need any additional clarification, Jess, you can just call me and I can show you some side-by-sides. So anyway, that's all I have for today, and appreciate you guys tuning in. And if anybody has any questions at all, please feel free to reach out. Thank you.